Welcome again, and thank you all for joining us for our Health Talks webinar. As you know, this is brought to you by the College of Health Solutions at ASU. My name is Mara Aspinall. I'm a professor of practice and co-founder of the college's biomedical diagnostics program. The College of Health Solutions is the place where we address the challenges facing people and communities to be healthy, to stay healthy, to improve everyone's healthiness, and to manage chronic disease. These health talks are just one way that we serve the community with relevant educational content that also provides continuing education credit at no cost for health professionals. We look to provide and to bring to you the most current issues in healthcare today, and it's hard to find a better example of that than today to talk about COVID-19 vaccines. We look forward to an active discussion amongst our speakers, but what we need from you is we need questions, we need your comments, and we're going to do some poll questions where we want your opinion on an anonymous basis. So this is going to be a highly interactive session. Even though we can't see all of you, we know you're there. And we want you to be part of our conversation. So first, some housekeeping items. Number one, the session is being recorded and it will be posted on our website at asuhealthtalks.com. After our panelists have each had a chance to present, we will address your questions and comments, and we will bring poll questions into our session, and then our panelists will comment on the polls, and we will continue to ask you some questions as to where you are on the vaccine issues. Let me clarify, and I think at this point of the pandemic, you probably all know, but just in case, please submit your questions using the Q&A feature at the bottom of your screen. And when you go into Q&A, just type your question. And finally, after the event, we want your feedback. You will receive a brief survey to ask for that feedback and your input about today's webinar and other issues in the future. If you are requesting continuing education credits, you must complete our survey to receive credit. If you do not apply for CEUs, we would still appreciate your feedback as we continue this series and we look to improve it. So with that, as you very well know, today's topic is the current state of COVID-19 vaccination, protecting our children and adults, not just in the US, but around the world. Joining us today are two fabulous speakers, Dr. Angela Valdez-Huizar and Dr. Bruce Gellin. And we're going to be informal today. So Angela, I hope you don't mind if I just use your first name. But Angela is a pediatrician with Phoenix Children's Hospital. I would say, in addition to her very busy life as a physician, she is also a clinical professor with the University of Arizona College of Medicine, the Mayo Clinic Alex School of Medicine, and Creighton University. Angela has a special interest in pediatric care for kids who have endured child abuse and have socially complex, who are socially complex patients. She has really done tremendous work in working with the homeless youth outreach and caring for the most vulnerable pediatric populations throughout the Phoenix area before she transitioned to the Division of Primary Care, Complex and Adolescent Medicine. I'm going to introduce our second speaker briefly now, and Bruce is actually going to be the first one to present his slides. Our second speaker is Bruce Gellin. He is one of the world's premier vaccine and infectious disease experts. We are thrilled to have him with us. He is Chief of Global Health Strategy at the Rockefeller Foundation. And in this capacity, Bruce leads Rockefeller's Global Vaccination Initiative as a leader in the new Global Pandemic Prevention Institute, otherwise called PPI. PPI's mission is to avert future pandemics by identifying and responding to the earliest alerts of a disease outbreak. Bruce has dedicated his career to protecting people from infectious disease. Before joining Rockefeller, he was the inaugural president of the Global Immunization at the Sabin Vaccine Institute. He has worked with CDC, HHS, and is an expert advisor to the WHO on global immunization and vaccination. So actually what I'm going to do as we'll get ready for Bruce to give his remarks, and what both Bruce and Angela are going to do, they have so much more than we could ever get through in our hour session, but they're going to give some high level remarks, talk about the key issues. And what we really want to do is have the interaction with you. But before that, I'm going to see, Jane, can we test our first poll question? And then over to you, Bruce. I'm hoping this will make people smile. What is the definition of a breakthrough infection? And indeed, you have only a single choice. And the first one starts with the Kool-Aid Man. Second one is a new musical artist. The third one is an infection offering superpowers. So we won't spend a lot of time on this. Clearly, the process works. I appreciate a vote up there for the Kool-Aid Man. But clearly, all of you know, and we'll be talking about it today, that it's an infection in a vaccinated individual. So with that, Bruce, over to you. And we look forward to your remarks and then our discussion.
Great. So can you see, let me make sure I get on full. Is that, can you see my slides?
Perfect. Thank you.
Okay, great. So Mara, thanks for organizing this. This is these are the best when we can really just sort of instigate a bunch of a discussion through this. And as you said, that my role here is really a tasting menu to give sort of big picture, global, historical, a number of different issues. And Angela will do the same in a different category really, and then we can open this up. So I just wanted to use that opportunity to lay out a number of different things that are global, historical, maybe a little bit political. I'm in Washington, D.C., so you can't avoid the latter. You know, I think that this is something that we see every day. We've seen the tickers on this, and it goes without saying that this has been a catastrophe. And the sad part is that we know things like this were going to happen. We could predict that they will happen. And despite what we thought were preparations, I spent a lot of time in government on that. We can see what happened both in the United States and around the world. We won't go through the numbers. You've seen all these. And I think the message for people in health is that, you know, that a pandemic starts off as a health problem, but it then becomes a global, social, economic, and national security issue. And we're seeing this play out. You know, just a little bit of history that when I got into this, it was when the talk of the day was about the Spanish flu of 1918. And those of us who do this kind of stuff celebrated 1918 or 2018 as the century. So there's all kind of, we all were on the lecture circuit for these things. But just to go back, because this was the indication of what these kind of things would look like when you had a rapidly transmissible virus infection. Now we have color pictures of all this stuff that was just black and white then. And personally, I was in it in the bird flu era, which seems like ancient history in 2004, 2005, when this was the threat that was upon us. And the good news of that is that at least woke us up to what the potential would be. And a number of things that both the United States and other countries did in service of preparedness. And while we're clearly better off than we were, there's still a lot to do to get it right. I just wanted to, this is another piece of ancient history that you'll remember this from the early days of COVID. This also comes back from the flu era and this idea of flattening the curve. And so the unspoken, the spoken part of this is that the goal of flattening the curve was to keep the healthcare system going. That with the concern that with so many people sick, it would overwhelm the healthcare system and you'd have this decay of care overall. And it would then have implications on those who didn't have COVID because they weren't able to access the healthcare system as well as those who did. And we've already seen pieces of this where what's referred to as, you know, altered standards of care, which is sort of a code word for saying you're not going to get the best, and hopefully you get something that will keep you going when there's not enough for everybody. But what's unstated about this flattening the curve is what's it all about? It was in the flu era, it was really about keeping things in check long enough for a vaccine to show up. And so what's not in there would be all the way at the right is, okay, a vaccine is finally there. We can help to control this, and that will keep things down. And it's about the idea of suppressing transmission until that happens. And in the flu land, it was, at least there was a way to make flu vaccines. We understood how they would work, and had sort of some calculation for how long it would take for a vaccine to become available. When this image was in the early days of COVID, it was unclear how long it might be until a vaccine would become available. And you'll remember the discussions were, people trying to be optimistic, saying, well, maybe 18 months or 2 years, or it could be longer, or it could be never. And obviously, people don't like to hear that. But and then we saw something that was truly miraculous, is the development of a vaccine in a short period of time. Also from this, the era of flu, is this idea of layered protection. And this gets into what's referred to as either public health measures or non-pharmaceutical measures or mitigation, all the things you can do to try to keep a virus from exposing people. And so this idea was that none of these is perfect, but like this iconic Swiss cheese, if you lined up all the pieces, it was still a solid piece of cheese, even though there are holes all the way through it, as a way to try to dampen things. I say that because without a vaccine or a therapy, that this is the only control that you have, which frankly would be no different than it was 100 years ago. If we can get into a discussion about the role of diagnostics, and how they can help people both understand what their ailment is and what they can do about it in terms of either treatments if they're available or their behaviors, but that plays into this as well. Our focus here is on vaccines. And leaning into the topic of the COVID vaccines a little bit, just to talk a little bit more about some of the implications of some of this non-pharmaceutical community mitigation. We remember in the early days, there was a lot of discussion about contact tracing as a way to try to control things. Well, that didn't really work out that well, and the system became overwhelmed, and nobody talks about it anymore, or they rarely do. But I just wanted to feature that in other places, there are other systems in place to try to help, put that in quotes, help with some of these control measures. So in China, depending on the local situation, your phone tells you whether or not you have mobility. And we've seen things like this in other countries with these either vaccine passes or green passes, but there they know what the situation is in the background. There's plenty of data to inform that, and that affects what people can do, because their phone is their fast pass, whether they can leave the house and move around, or to what degree they have mobility. So just to spend a minute or two on the global vaccination piece. We've seen how quickly a vaccine became available, and we see what are truly, unfathomable volumes of vaccines, and watching what's happened around the world. But I wanted to just focus a little bit on the global goal, because we don't often hear about this as much in the United States. And we've also, I think, are familiar, no matter where we are, with the huge inequity that those who have it took a while, but now have a lot, and those who don't have are barely getting any. And we'll get into some of that, so you can just see how stark that reality is. But the global goal was to have 10% of the world population immunized by September, and now 40% by the end of the year, and 70% a year from now. And these are numbers that are targets. They're not really that meaningful in terms of what is supposed to happen as a result. It's not the same as herd immunity. We can talk about that if you like, but it's really just trying to think of what these goals are going to be and how we're going to attain them. So we're almost at the end of November, and it's going to be something to try to get to 40% globally, which is not going to happen. If you haven't seen this website, this One World Data. It's really remarkable, the wealth of data in it. And if I was any good at PowerPoint, I would be able to do this in an animated way where you can watch over time the colors appear, at least in those places where the vaccine was available. But it just gives you a sense of the stark differences between the darker the color, the more vaccine you have, and so there it is. You can see who has and who hasn't, and I think that's an important part of the message. But here's the data that more than half the world population received one dose. Almost 8 billion doses have been administered globally, 8 billion doses. And 30 million doses are administered every day around the world. But in the low-income countries, less than 5% have received at least one dose. And those are average numbers, which means some have a little bit more, but some have a lot less. And so we've heard a lot about this inequity. We've seen this story playing out of what's been called vaccine nationalism, of countries hanging on to the vaccine they have. That's fodder for some of our discussions, but just wanted to make sure you're aware of that reality and aware of what some of the global goals are. This is about to change, and this is about to change dramatically. And so what you see here is the projections on what the vaccine supply is likely to be over the coming year. So start at the far right, that's 2023, then 2022, and now here we are at the end of the year. And you can see at the end of this year, there'll be just around 8.5 billion doses that have been produced and distributed. And look what's going to happen next year. And so that's what I really wanted to focus on, is right now, you've already seen that the have-nots have little, but soon this is about to shift where the vaccine volumes will be massive. And the question on the table is how well countries are able to turn vaccines into vaccinations and the challenges with that. So the related piece of this is, we've talked a lot about the vaccine supply, which is important, but when there's a supply, will people come? And we've started to see that it's the supplies are increasing, but the vaccines are not turning into vaccinations equitably around the world. And we're going to spend a little bit of time on that. So what's the issue? We've already seen that there was this 10% goal in September that most didn't hit. But just take a look. I won't read these to you, but just take a look at the issues on the table to have the programs in place. Whether it's, do they have access to the funding to do the planning? Do they have the manpower to mount these massive campaigns? One piece that is worth thinking about is, as countries get multiple different products, how they manage them when they have different temperature requirements, different storage requirements. In Washington, and I'm sure Angela will get into this, in Washington, we've already seen stories as now there are vaccines available for children. There have been a lot of screw-ups where the kids are getting the wrong doses because they're using adult vaccines rather than child vaccines, only to say that each of these vaccines has their own delivery characteristics. It can be confusing, and you can imagine in an emergency that things may not go perfectly. There's also the issue which is here of shelf life. I think the flip side of that is the expiry dates. So as vaccines are starting to move around the world, as countries are donating them, which is a good thing, you don't want them donating vaccines that have very limited shelf life left and are about to expire, because basically it's like hot potato where the countries are stuck trying to figure out what to do with vaccines, and nobody wants to be caught wasting it. So this increasing volume that's about to happen is going to be the next challenge. And then just a few other challenges that we talk about. The need for supply, the need to, what's referred to in the trade as sort of the absorption capacity. Countries are able to take the vaccine from the docks and get them into arms. But then there's the issue about down the road and downstream of how excited are people about being vaccinated. We've seen that story played out in the United States, where there's, for lots of reasons, people are making their decisions, they're not interested, some more political than others. And not to say that misinformation and disinformation are the only story, but that's certainly playing into it. Just two things to feature here, that there's a group, who knew that there's a group called the Center for Conquering Digital Hate. And they track mis and disinformation. And there are a dozen people, so you can go and read this report, a dozen people responsible for 2/3 of the nonsense that's going on social media. And you can see how these messages get propagated around the world and turn into seemingly valid points in other places. Another study that was done a couple of years ago was looking at what they refer to as this online competition between pro and anti-vaccine views. The short story here is the blue guys are the good guys, the green guys are undecided, and the red guys are the bad guys. It sort of is. And the point is that they're in separate worlds. That the pro-vaccine public health is essentially in an echo chamber. They're not really penetrating those who are trying to be undecided. And the premise of this study is, when looking at the activity that was occurring in a certain period of time, how much more active those who are trying to dissuade people are from vaccinations through a number of different mechanisms. And so you can see here how some of it plays out. This is just one slice of how this is being seen in a number of different African countries, about the death toll has been exaggerated, or that it was developed in a lab intentionally for evil purposes, which we don't have to speculate on, but there's plenty of those who do. But that's also part of the ecology. Not all of it is about the anti-vaccine sentiment. A lot of it may have to do with convenience or complacency. If people have busy lives and they don't see this as such a big threat, are they going to try to show up and to get vaccinated? Or if they have to walk, 5 miles to go to a place that has limited either supply or limited clinic hours. So that's just to give you a sense of sort of what some of that backdrop is. Rockefeller is supporting a group called the Social Science Research Council. So if those of you are social science researchers, you might want to take a look at this to try to look at the impacts of mis and disinformation on COVID vaccination globally, in the United States and globally. And then last, this is my Thanksgiving message. I started with bird flu and I'll end with turkeys, but about how people calculate risk. We do this all the time, sometimes more overtly than others. But this is a piece that was in the Washington Post just over the last couple of days about what people should consider as they gather with their families for Thanksgiving. These are just a couple of the factors, but what's the vaccination status, the people who are going to be around the table, who has got underlying health risk factors, what's the background rate in the community, and then the setting, which is really about inside or outside, the density. And those are just a few of the factors. We're making these risk assessments all the time. And maybe someday we'll have a riskometer so we can try to figure out in any given setting, in any given situation, what we do. So I just wanted to leave with those thoughts and then maybe turn over to Angela, and then we can get into a discussion. Thanks.
So thank you, Bruce. That was as you say, a tasting menu, quite an extensive one, broadly on COVID, on infectious disease, and particularly on vaccines. We're going to shift as we hand it to Angela, but I'm going to try to do one more poll question because it's something that you mentioned, Bruce, in your talk about vaccine passports. So we're going to come back to this. But Jane, are you able to put up question number 3 on vaccine passports? Perfect. So as everyone could see, the question, again, answers are anonymous. Which is, should the U.S. issue vaccine passports to validate your vaccination status, whether it be for travel, for indoor activities, or otherwise? So we are, and now I know how to share the poll. We're going to do these quickly. And when you see the results, Bruce, this will give us something to talk about because I'm not sure it's consistent with what we hear from Washington and in many states. 88% positive on vaccine passports, 13% negative. So with that, we're going to shift now. And a lot of what Bruce spoke about was clearly global, but the topic at hand are children. So Angela, who has tremendous experience, a pediatrician and runs a number of clinics, is going to talk to us about vaccines in children specifically. Angela, over to you. We can see your slides. We can't hear you though.
Can you hear me now?
Yes.
Okay. Hi, thank you for having me. I will, in being kind of mindful of time, try and go quickly because I know we want to get to the more interactive aspects. But as Mara said, I work at Phoenix Children's. So my point of the talk today is just to talk about COVID specifically in pediatrics, focusing most on the great news that happened this year with vaccines coming into pediatrics. So just kind of a quick rundown. I think a lot of us know this. At the beginning of the COVID pandemic, in our office, quite frankly, a lot of us were sitting around twiddling our thumbs. People weren't wanting to come in for well checks, and pediatrics wasn't hit very hard with the initial peaks of COVID. Unfortunately, with the new Delta variant, we did get hit a little bit harder and are seeing a lot more COVID now that adults are being vaccinated and schools are opening back up and things like that, we're seeing a lot more. So COVID-19 symptoms, these can really run the gamut in both adults and pediatrics. In children, a lot of them seem to be a lot more atypical presentations. So a lot of fever, a lot of abdominal pain, actually, some mimicking appendicitis type pictures. So vomiting, diarrhea, the run of the mill kind of GI stuff, neck pain, rash, not anything too specific. A lot of these could be attributed to, we played a fun game of, are these allergies? Is this another virus? Is this COVID? And so nothing too specific. Obviously, the loss of smell or taste is one thing that we see very commonly in adults. It's not as common in children, but it's not unheard of either. The big thing or the scary thing for us in pediatrics is those kids who go on to progress to MIS-C or multi-system inflammatory syndrome. And we can't predict who is going to progress to this. Healthy children can, children with complex medical histories can, and unfortunately we can't predict, which is the scary part of kiddos getting COVID. So what we have seen, and obviously our data is limited to the last year or so when we've been seeing COVID, I guess 18 months or so, is highest in kind of the 5 to 11 age group, which is going to be important kind of near the end of this talk. And we've seen about 5,000 cases of this MIS-C since the beginning of the pandemic, and these numbers are as of October 4th when I pulled the data. And about 60 to 70% of these kids are admitted to the ICU, and some of them do go on to die. And so in pediatrics, and if it's your own child, one is too many. And so this is kind of our big push to prevent COVID in kids, which we'll talk about in a little bit. And so the good news, pediatrics, we love our vaccines. We give lots of vaccines. And so in the last few months, we've been very excited to be able to open up vaccines to kiddos initially older than 12. And now in the last couple of weeks, open it up to 5-year-olds and older. So I just wanted to just quickly touch base on what the vaccine trials looked like. I think that is of some interest to people. And so the 5 to 11 one, which was just approved in the last couple of weeks, as I'm sure you know, had initially about 2,200 participants. The FDA did then ask for this safety expansion group. So there was an additional 2,300 participants. In each group, about 1,500 were the vaccine recipients, and the other ones were the placebo groups. In the 5 to 11 range, and actually in the 12 and older range, there were no cases of myocarditis or that heart inflammation that you may be seeing on the news, anaphylaxis or death in this age group. As Bruce was mentioning, the 5 to 11 is a different vaccination altogether. We're not just pulling smaller amounts from the adult vials. And so the 5 to 11 is the 1/3 of the adult dose, so the 10 microgram dose. It does look different to prevent these vaccine errors that we have heard of. And so the 5 to 11 is this orange cap appearing. It's the same as the adult dose as far as it's a 2-dose series spaced 3 weeks apart, so 21 days. The buffer, and kind of alluding to what Bruce had mentioned as far as shelf stability, the buffer is a little bit different than previous buffers, and that was in an effort to make it more shelf stable and to be able to be given to more people without waste. 91% efficacy after the second dose, which is great for vaccine trials, better than the flu vaccines that we give yearly. And then just quickly on the 12 and older, so similar numbers in these subsets. There was 2 age groups in this, so the 12 to 15 was about 1,100. And then about another 1,100 or so were in the placebo group, and kind of similar numbers in the older range. This is the same dose that we are giving to adults, so the 30 microgram dose, the purple cap. Same 2-dose series spaced 3 weeks apart. This has that PBS buffer that is same, like I said, it's the same vaccine as adults, so same buffer as the adults. This is one of the differences in between this vaccine and the youngers. And this vaccine actually was much more effective in the 12 and older age range than it even was in the adults. So 100% efficacy after the second dose in clinical trials. And so talking about, I mentioned that we weren't hit as hard in pediatrics as the adult world was with COVID. But just because kids weren't initially getting as sick or are not getting as sick, don't have as severe of illness, the hospitalization rate for children is much lower than in adults. It doesn't mean that kids haven't been significantly impacted by COVID. And so, we have about 18 months to 2 years of data with COVID. And so we don't know kind of long-term sequelae of COVID in pediatrics or in adults for that matter. But so the thought of future medical issues. So looking at morbidity as opposed to just mortality. So they're not dying, but are they then going on to have, complex medical issues that we're still learning about? So long-term sequelae are who's going to turn into a long hauler and who's not. And then, in pediatrics, we often think about participating in sports because we do a fair amount of sports physicals. But somebody who had COVID, we have to think about that. Can they participate in sports? Is this going to affect, lifelong goals or career aspirations or things like that? And so another thought. So the other thing, as I mentioned, we were kind of twiddling our thumbs at the beginning of this. A lot of people did delay medical care. So we're seeing a delay in vaccinations, a delay in well child checks overall, delays in treatments. You wouldn't be surprised the number of kind of progressive cancer diagnoses that we were seeing in pediatrics of people who were just too afraid to go to their physician or to seek emergency help. And these are obviously delays in treatment for certain things can affect the mortality of a disease process, but also the delays in vaccinations. Are we going to start seeing pop up increases of, measles, mumps, rubella, varicella, things like that with these delays in vaccinations? So the other aspect to think about is loss of school, not only the learning aspect, and there are some studies that talk about kids losing about 1/3 of their education in the last 2 years, but also the social aspects and the mental health aspects that come with not being at school, especially in a lower socioeconomic class. Being at home with parents more often, we saw a lot more or an increase in abuse. The same thing with the lower socioeconomic status. A lot of those kids get their main source of nutrition through school. The schools got smart and kind of opened up for those kinds of things, but it was kind of a secondary thought. And then the other thing is an impact on families. So a lot of these kids have had caregivers or parents who have either been hospitalized or ended up dying from COVID. So what happens to those kids after? And so in pediatrics, we are obviously always interested in preventative medicine. And so we look at ACE scores or adverse childhood experience scores. And these kids who've had a parent or a caregiver or a loved one or any family member, friend, they have inherently elevated ACE scores with that and go on to have all of these, the risk of all of these other problems, mental health issues, higher risk of sexual abuse, other types of abuse, housing instability, things like that. And so the toll it has taken in pediatrics is more than just these kids are faring pretty well with a COVID infection. It goes far beyond that. I think one of the things that people are very interested in and is all over the news right now, so I just wanted to touch base on it briefly, is the thought of myocarditis. So in our two age groups, the pediatric age groups, there wasn't myocarditis reported in the clinical trials. That's kind of to be expected. The numbers were relatively small, and this is a pretty rare vaccine-related side effect. And so I'm not going to read everything. You can look at the numbers, but
yeah,
myocarditis from the vaccine versus classic myocarditis are very different. Myocarditis related to an actual COVID infection is far less transient than it is in post-vaccine. So you'll see long-term effects. Most of the adolescents who did go on to get myocarditis related to the vaccine, most of their symptoms resolved in about 35 days. And so it's more common in adolescent young adult males. We're not sure why, maybe genetics, maybe hormones. And then this slide, I won't read it, but excuse me.
And Angela, I know we're running out of time. We want to do Q&A, but
Yeah.
will you make your slides available to people so they can read them in more detail?
Of course, yeah. And this is just a slide from your local epidemiologist. If you guys don't know her, you should get to know her. She's fun. But this just talks about some parent concerns. I talked about the myocarditis. I talked about the need. The vaccine is effective. Yes, there are side effects as with any vaccine, but we are seeing that side effects in pediatrics is much more or less common, especially in the 5 to 11 age group. And maybe that's because it's a lower dose and dose dependent. And then just quickly, the contraindications for COVID vaccine is simply just if you've had any anaphylaxis or severe reactions to any component of the vaccine. You can talk to your doctor about that.
Super, Angela. Oh, and thank you for the references. So we'll make the slides available. And Jane, can we go to question number 2? And then we're going to try to take as many questions as we can from the Q&A, and please post your questions. Now that Angela has given us the background, I am curious, should children over 5 be vaccinated? And as you can see, yes, leaning towards yes, maybe in the future or no, and really understanding, still deciding. And we've got some great, great questions. I'll give it still people coming in, so a few more seconds. I'm going to end the poll and share the results. So again, we have a different mix than nationally, where we have 76% yes, definitely, leaning towards yes. So in total, we're at 87% vaccinated. I suspect, I know, and we all know that that is not typical of what we see around the country, whereas most of the polls will say 2/3 of parents are leaning against giving their kids the vaccine. So with that, Angela, Bruce, thank you very much. I'm going to start with one question for both of you that comes from an anonymous attendee. And Bruce, you may have read this, but it was really questioned by your comment about the online ecology of Vax viewers. And but really asking both. We have an attendee who is pro-vaccine, pro-mitigation efforts, but does not want to get into fights with folks online, or I'm going to say at their Thanksgiving table. And this is reminiscent of a few years ago when we had political conversations right before, right after an election. Let me ask both of you, because I'm sure you're dealing with a lot of pro-vax, anti-vax, and just plain frustrated people. Bruce, let me start with you. What are some of the strategies we can take to be more pro-vaccine, but not have an argument?
Well, if it was that simple, it would have been in the slide. No, it's really a great question, and it is the perfect one for Thanksgiving, because this will be the topic. And it starts as actually, in a way, it gets back to, risk assessment of what are you going to tell people when you invite them over? Are you going to have requirements if they should be vaccinated or not? That's where it's going to start this, because you're trying to provide a safe environment. So, to me, this is it's a different and more politicized version of what Angela must see all the time in pediatrics about those who have questions about routine immunizations. And I think, to me, the question is trying to figure out what exactly is the issue for that person. Is it because something bad happened to their neighbor? Is it because there's some political ideology? So, like medicine, it starts with a diagnosis and trying to figure that out. It may not be something you can solve. And I've been struck by the number of people who talk about this, that even in our world, people have plenty of people who are either neighbors or family members who have this stance and who are essentially unmovable. And I don't, so there's not a great answer. I think that part of it, I'm surprised that it has persisted. And I think it plays out very differently in the United States, given the politicization. Early on, it was not a surprise. You know, there's a lot of people who said, let's wait and see. Okay, 8 billion doses later, what are you waiting for now? So there's plenty to see. And despite those clinical trials, now the wait and see as well, is there some long-term thing we don't know about? Okay, fair question. And you're never going to know because only time will tell. So I think to try to have a conversation and hear what people are saying, because increasingly as people talk about this issue, people aren't crazy. Some of them are, but they're not crazy, and they're trying to figure out how do they get to this position, which is so much against this wealth of evidence. What's behind it? So I said that's a long way of saying I don't think there's an easy answer here, other than trying to have a conversation about it and see if some of these things can be teased out. A lot of this is emotional more than rational, and you can provide people all the data they want, and they'll still say, yeah, but. Angela, you have more success than I do?
So like you mentioned, I mean, this is a pediatrician's realm. We deal with this all day, every day. This is not new for COVID. I feel like we've been training for this our whole life. And so I think, when you'll read about vaccine hesitancy, not just with COVID, but this applies here as well. There are those people on the opposite ends of the spectrum. There are people who are gung-ho, I'm going to get every vaccine because that's what I believe in. And there are people on the other end who say, I'm not going to get this vaccine no matter what anybody tells me or what I'm forced to do. The large majority of people, luckily, are kind of somewhere in the middle of this spectrum and not on one end or the other. And like Bruce mentioned, I think our job is to kind of try and meet people where they are. There are people who you're never going to convince, and that's not worth spending your time on or arguing with. Those are just people that you tell them, we're never going to see eye to eye on this. We're not going to discuss this. And there are other people on the other end where they'll say, yeah, give me any vaccine. So you spend your time on those people in the middle, who you can give information to, providing facts, seeing what their concerns are and trying to provide them with as much information as you can and giving them reputable sources and not just, some friend of a friend who said this on Facebook.
Yeah. I really appreciate both of your answers and quite frankly, the transparency of them. I don't know if we can do any poll questions, Jane or Leo or Julie. If we can do question number 7, I'm going to ask people what they think about how to influence. But if we can't do that, we're going to go to the next question. And this, here it is. It's coming up. I'd love to get our audience's view. What's the best way to influence those who are skeptical? And as you can see, the choices: celebrities, doctors, news stories. Is it all about money? Or as I like to see, there were a lot of people who were motivated by a dozen donuts, or not convincible. You'll notice that we didn't put on here work mandates, because we're going to separate those for a moment. And we'll give this another couple seconds as people are voting. And I want to share the results here. And as you could see, interesting split. I think the vaccine community, and Bruce, you can talk about this, but has decided that celebrities don't help. And which is consistent with what we've heard more about the news stories about being unvaccinated and a little bit on financial incentives, and about nationally, correct, don't bother for the 20%, as Angela said, you may not be able to move them. So now let's move on to the questions. We have one of our first question.
If I could make just a comment on that one. I should have proofed this better. To me, the answer that I would have given, that it wasn't on there as a choice, was more local voices. So I mean, who cares about the Surgeon General or some guy in Washington in a suit? I think the more people that people like Angela and people like you, that people say, well, these guys are at this local university who does unbelievable things, and that's what they have to say, because you can identify with people who are more like you. I think there's a need for that, for more community at both the community authorities as well as community more broadly.
Thank you, Bruce. And I think that was the intention, or at least how I interpreted it. The news stories about, the local news stories about the postman who decided to get vaccinated. But that's really helpful. I think we found, I suppose, just like politics, a lot of it is local and it's people you trust. Bruce, let me go to you on our first question that came in, which are vaccine passports exist outside of the US. Have they worked? Have people trusted them?
Yeah, well, there's a couple of things about it. One is that they validate your vaccination status. I'm not sure if you've gone through one of these drills where you have your driver's license and you show your picture card and all of a sudden you have a QR code. How that happens, I don't know, but it seems to work. So I think that that's an important first part of that, because I mean, these ridiculous cards that CDC has, anybody, any child could forge those in 5 seconds. So and they're pretty flimsy philosophically as well as structurally. So, but you can already see how those are going to be needed. In other countries, it's been an incentive on a number of reasons. I mean, there are plenty of people who don't like it because it restricts them. You saw this slide I have from China where I was surprised, frankly, when I heard someone from China talking about it. That's just the way it is. If it changes color, you don't go out. It's a different philosophy of life than we have. But in other places, it's been a real, it's opened things up. It's what allows you to go to the theater or to go to a sports game or to this. And now it's increasingly for travel. I mean, so at one level, the idea that there's not an international standard is crazy, because if you're going to start traveling, you got to have a different code for every place you're going to go. That's not going to work. And the U.S. government's been reluctant to own the problem. So instead, the private sector has taken over because they want to provide safe airlines, safe retail space, or the like. So I think the experience generally has been pretty good. It's now becoming increasingly a social norm within the United States. Some states have issued their own. And I think that you're going to see increasing venues that say, if you want to come here, you show us that you're vaccinated.
And Angela, I'm going to bring it to thank you, Bruce. And, there have been increasing stories about physicians refusing to see patients who are not vaccinated, and really taking this to another level and not providing access to routine care. Has that come up in your institution? Is that something you've talked about or you can talk about?
So just like the previous question, this is not new in the world of pediatrics. There have been clinics throughout, the United States who don't see patients who don't follow a certain vaccine schedule or things like that. So, I see both sides of it. The AAP does not recommend that we do that, only because we're limiting care, care to children who probably aren't making that decision for themselves. But also, our clinic is, but specifically, we see a lot of very medically complex children who, if they were to contract COVID, would be at much more high risk. And so have we thought about it? Yes. Is it practical? Not for us. But I do see why a private practice or something like that would be interested in that. And I think it's the same, as going to, Gamage Auditorium for a play. I think you're protecting as many people as you can. So I see both sides of it.
So if we take it from there, we got a question from the audience about how do we fight COVID misinformation. And the question is, how about listening to the individual concerns and addressing them with data, which, sounds good. But how does that happen? And I'll say one of the questions that I've had from my family, which is, there are a lot of kids in the world. There are a lot of people in the world, and kids in particular, 2,000, 3,000, 4,000 kids in a trial. Is that enough to really know that all different kinds of kids are in that trial, and then this won't kill or hurt my kid? And you're nodding, Bruce, but Angela, we'll start with you. And then Bruce, you must get this question, particularly around the world with a lot of different ethnicities. Are we doing the trials broad enough and deep enough? Angela, how do you answer that question?
Yeah, so we do get the question a lot about the small numbers in the trials as compared to, like the HPV vaccine trials where there was 20,000 in the initial studies. So yes, it is smaller, but I think, Dr. Offit always talks about kind of risks, benefits, and he talked a lot about polio vaccine and how people wanted more information about polio. And so they continued to do trials. And in that time that they were doing continued trials, children died, children became paralyzed. And so I think this is one of those risk benefit type things. Do we do more studies on more kids and risk other children not in the studies or not getting the vaccine, getting MIS-C and those long-term sequelae? Billions of adults have gotten it. It's proven to be safe. Lots and lots and lots of adolescent patients have gotten it. It's proven to be safe. So we have data. And historically, most of the vaccine-related illnesses happen in the first 2 months or so. We've got data past that. And so, I think the argument of providing facts to people, for some people, I think that works. But I think for some people, you'll give them a fact and they'll shoot something right back out at you.
Yeah, that is absolutely true. So Bruce, how do you answer that question? And when you talked about 53% of the world has had one dose. I know it's not enough, but it's still pretty extraordinary that 53% of the world could do anything in a consistent manner. How do you deal with this question, particularly in populations where in ethnic populations where the vaccine might not have been tested?
Yeah, I mean, so in the U.S. in the initial studies in adults, they were huge. They were 40 to 60,000, and that's one place where, among the things that the government did right in sponsoring some of those big studies, pushed the companies to make sure that there was adequate diversity. It wasn't perfect, but at least it was enough because they wanted to make sure that there was some answer to the question when people said, "Well, what about people like me?" So it's not perfect, but at least there was some of that. And I think that's similar around the world, where you can never get every type of population in there, but increasingly you have those, and then you have the experience, the real world experience of giving the vaccines. I think on the children's one, it's a slightly different call, given that the studies that you cited, Angela, were a lot smaller. They were mostly to try to look at is the immunology the same that you could then draw conclusions from. And while it's reassuring that there's no myocarditis in it, in 2,000 people, you're not going to, you'd be unlucky or lucky, depending on your philosophy, to see any of that. And you give credit to the people who are in the study to take the risk themselves of not knowing, because children are not little adults. And then those who are the early adopters. But we've learned a lot about that. So now you have a huge amount of experience. And I think in the early days, and I think still is that case where a number of parents are wary because they're littler kids, because there's less study. I think, and Angela touched on it well, I think this myocarditis got, I don't want to say overblown, but over accentuated. And I think that the point that she made is critically important, that myocarditis from this disease is bad. And myocarditis from the vaccine seems to be a different disease and seems to be more transient. So it's not an apples to apples comparison. But I think that the aggregate experience, and I should know how many doses have been given to kids under 12 now, but it's in the millions because there's been a lot of experience. That I think is reassuring, which is back to the point of, giving people data is probably, you need to give them some data, but they really need the story that goes with it. Because telling people about numbers, they're going to say, yeah, but what about me? What about that 1 in a million? And you can never have an answer for that. So I think that and that's also where Angela's got too much experience of that same thing in routine immunizations, and to tell people the facts, but to also with them tell the story. What she does for her own children is a very powerful message. What experience she's had taking care of some of these other children. There's data embedded in that, but I think the stories are the ones that people are listening to because they want to know, well, what happens if I don't do this? And it's more of a story than a statistic.
Super, thank you. Thank you both for that. We've had now a couple of questions about these anecdotes, and I'm going to take it from a few of them in terms of people who have had COVID and clearly have survived. I I think that, at least in my circles, is the one that is most common. I've had COVID and therefore I don't need a vaccine. Angela, you want to start with you again? How do you deal with that? Either if it's, there have been a number of kids with COVID. Is that a legitimate excuse or reason not to be vaccinated? And then along with that, I'll ask the second question is, are we going to be vaccinated every year for the rest of our lives? Angela, we'll go into the lightning round here because we've just got a couple more minutes.
Sure, just quickly about it. I think a lot of the information that we have as far as waxing and waning immunity is from the adult world as we're just, starting to vaccinate kiddos. I get the question often, if I had chickenpox, I don't need the chickenpox vaccine. We've got, years and years and years and decades of data about that. And we're just learning about COVID. And we're already seeing in the, 18 months, 2 years of this pandemic, we're already seeing people's immunity wane. So it's not predictable. And so my opinion is that probably this is going to be a yearly vaccine, just like influenza.
Bruce?
Yeah, I think that's the same. These are cousins of cold viruses, and for years people thought about making vaccines for cold viruses, but you couldn't do it, largely because the immunity from either the disease itself or from the vaccine was so limited. So I think that may foretell what the future is. Let's also remember these are first generation vaccines. They're miraculous, but they're the first ones out of the box. So I think going forward, we're going to need to think, how do we design these things that actually perform better or differently? And the differently would be longer protection of immunity, because we're already seeing that the waning is then leading to people to get boosted. That's a separate topic we won't get into, of how confusing that is, because now people know what to do and governors are now taking over and deciding what people should do in their states. But I think that's going to be an issue everywhere. And I think the bottom line is we're going to need to have persistent immunity. These viruses aren't going away. They're going to continue to mutate, which is a separate problem, but we're going to need to have immunity in individuals and populations to keep this from becoming explosive outbreaks. And vaccines will be the way to do that. And so we'll probably need different types of vaccines that can perform differently to provide better immunity, longer immunity, and maybe broader immunity against variants.
Well, I appreciate that. I'm going to go to question, Leo, question number 6 on the future. And as we're bringing that up, I'm going to, we'll do a couple of things at once and we'll go a minute over. Vaccine research for future outbreaks, what Bruce and the team at Rockefeller are working on. Should we start now or should we wait? So we're getting some comments here. And real quickly, do you see a vaccine for kids 6 months to 5 years coming about, Angela? Do you think we'll have a vaccine for our youngest kids?
Yeah, I think it's a moving target. Initially, Pfizer said that we were going to get some data by the end of this year. I'm not sure that's going to happen. We actually at PCH are trying to open up a study here for older than 6 months. So if that happens, I will be thankful for that. So I think it's a moving target. I'm hopeful.
Perfect. Call me because I'd like to bring my grandson into it. So with that, Bruce, I'll give you the last word. When you see the poll results here, 97% saying vaccine research for future outbreaks has to start now.
So that one person will be glad to know these are anonymous. But I think it does have to start. It's already going on. So remember that, wind back the clock when there were hundreds of candidate vaccines, and we've only seen a few work their way through. There's still others in the pipeline. I think that's going to be a challenge for the people who come after, because they're going to have to demonstrate that they're better to be able to. So that's a separate issue, but it's already starting, and they have to be better. Because for all the reasons we know, because we're going to need immunity for a long time in individuals, and unless we have vaccines that can do that now, we're going to need different vaccines that can do that.
Wonderful. Well, with that, we are actually over time, so I'm going to get into a bit of trouble. But let me say thank you. Please follow the College of Health Solutions on social media. Our next health talk will be on Thursday, December 9th, also at noon Mountain Time or Arizona time. And that talk will address the health of the healthcare workforce, because none of this is possible without all of them. Please follow ASU College of Health Solutions on social media. And thank you, Bruce and Angela, for a great conversation and a lot of interaction. Everybody stay safe out there and have a terrific Thanksgiving.